Thanks so much, Dr. Friedoff. Our final speaker today is Joe Moser, Director of Indiana Medicaid, and he joins us today to share their efforts to keep kids and families covered in Indiana through their various programs, including the Healthy Indiana Plan 2.0.
Hi, good afternoon, everyone. I wanted to thank you, Catherine, for the invitation to be on the webinar today, and thank NIHCM for inviting Indiana to participate in the webinar. So I do want to talk today about how we cover kids and families in Indiana and some of the various programs that we cover our populations in, and really focus today around pregnant mothers and our various coverage programs for pregnancy, and because we really believe that a healthy start in life begins with a healthy pregnancy. And so we've spent a lot of efforts in Indiana to address infant mortality. I want to share some of those today. So I'm going to talk about our campaign to reduce infant mortality. It is a statewide campaign that's been going on now for about 2 years. I'm going to talk about the coverage availability programs through the HIP 2.0 maternity benefit and maternity coverage in the Hoosier Healthwise program. I'm going to talk about plan selection for managed care companies and auto assignment into managed care for pregnant mothers. I want to talk about some changes we've made recently in early elective delivery policy to not pay for instances where a delivery is earlier than 39 weeks. And finally, I'm going to talk about long-acting reversible contraceptives, LARC coverage, and some reimbursement changes we've made in Medicaid to pay for LARC. So in Indiana, we rank very low on infant mortality, and it's really been a priority of our governor, Governor Mike Pence, and the state officials at the Indiana Department of Health and the Family and Social Services Administration to address infant mortality and how we really combat the death of infants younger than age 1. We do have the 6th highest rate of infant mortality in the country. 8 in 1,000 infants die before age 1. In 2003, that was about 594 infants who died. And our infant mortality rate among blacks is about 2.6 times the infant mortality rates of whites in our state. So it's a significant problem that we've been addressing in a variety of ways. The state has created a perinatal quality improvement collaborative, bringing together stakeholders from various areas to really look at solutions to address infant mortality and make recommendations to both state policymakers and to the provider community about how to address infant mortality and improve newborn health. That collaborative has included individuals from the state government, the Indiana State Department of Health, the Indiana Department of Insurance, who regulates private insurance, and Indiana Medicaid. Also has included various healthcare providers in the state. So our hospital and physician communities are highly engaged in the committee to address infant mortality. The academic community, we've brought together individuals from the IU, Indiana University School of Medicine, and other academic institutions. And finally, advocacy organizations, the March of Dimes in particular, but many organizations have come together to serve on the collaborative to really make recommendations to reduce infant mortality in the state. And we are starting to make inroads in doing that. I want to talk briefly about the coverage landscape in our state for children and pregnant mothers. So Indiana, we do cover about 674,000 children. Our eligibility rate goes up to 250% of the poverty level. Most of our kids are enrolled in the Hoosier Healthwise program. We do have some age, blind, and disabled kids or kids on disability who are not in Hoosier Healthwise, but a separate managed care program. And our kids on Medicaid, the lower income kids, do not pay a premium for coverage, but do pay co-payments. Our CHIP kids, those who have a little bit higher income, but are under 250% of poverty, do pay a small monthly premium to receive coverage, and they do have co-payments for services. Our parent and guardian categories, previous to our expansion through the Healthy Indiana Plan, we covered parents up to 24% of poverty. With the Healthy Indiana Plan expansion, which we started this year on February 1st, we now cover parents and non-parents up to 138% of poverty. All of the parents have been transitioned to the Healthy Indiana Plan, and so they're all now enrolled in HIP. We took the group that previously had been enrolled in Hoosier Healthwise, the low-income parents, and we received authority to transfer them to the Healthy Indiana Plan to participate in the coverage that looks much like a health savings account. They pay a small monthly contribution for a better benefit package in the HIP plan. Those who do not make their monthly contribution are in a benefit plan with a little bit less benefits. If you're a parent, caretaker under the age of 19, you would not be in the HIP program, but instead in the Hoosier Healthwise program, because you would still qualify for children's coverage. And then finally, we have about 40,000 pregnant mothers who are in our program. About half of all pregnancies in the state deliver on the Medicaid program. We do cover pregnant mothers up to 208% of the federal poverty level. We do have both hospital presumptive eligibility and presumptive eligibility for pregnant women. Those are for the PEPW program is for physician practices. So if you're a pregnant mother, you can get into the presumptive eligibility program at a hospital or at a physician's office through the PEPW program. And our pregnant women can be enrolled in either the Healthy Indiana Plan or the Hoosier Healthwise program. So there are essentially two options for pregnant mothers in Indiana for coverage, depending on income and other factors. We did, in our Healthy Indiana Plan 2.0 program, create a maternity benefit for the first time. So the original Healthy Indiana Plan started in 2007, did not cover pregnancy, and if you became pregnant on HIP, you had to transfer to the Hoosier Healthwise program. We felt that did not ensure continuity of coverage, and so to really help encourage that continuity coverage, we did create a maternity benefit in HIP. So those pregnant mothers who were already in the HIP program can stay in HIP and deliver in HIP under certain circumstances. And I'll talk a little bit more about that. They do not make a power account contribution, so there's no financial requirement when they're pregnant, and their cost sharing is shut off during their pregnancy. Only the current women on our HIP 2.0 program can be on HIP while pregnant. If you are newly eligible, that is, or you were not already in the HIP program, but you're coming into coverage for the first time, you have to start out in the Hoosier Healthwise program. We're also required to give pregnant women the choice to leave HIP and go to Hoosier Healthwise, or if their redetermination period comes up while they're pregnant, they have to be switched to the Hoosier Healthwise program. So we think those requirements actually don't encourage continuity of coverage, and we would like to see the ability to keep pregnant women in the same coverage program that they started out in, that they would prefer, and I'll talk about why that's important. Our Healthy Indiana Plan does cover all individuals in the state less than 138% of poverty. We do reimburse providers at a higher payment rate. So in the Healthy Indiana Plan, we reimburse at Medicare rates or Medicaid plus 30% if there's not an equivalent Medicare rate. There are maternity and pregnancy-related Medicare rates because of many individuals on disability who are in Medicare who actually do deliver on the Medicare program. We also provide incentives for healthy behaviors, and the HIP program really encourages the receipt of preventive services while you're in the program. And then for newborns who are delivered while their mothers are in the Health Indiana plan, they're automatically in our newborn coverage in Medicaid for up to 1 year. Now, Hoosier Healthwise is our program for kids and other pregnant moms who are not on the Health Indiana plan program. The Hoosier Healthwise program are for those pregnant mothers newly enrolling into coverage. So if a pregnant mother applies for coverage for the first time and isn't already on HIP, they would be placed in Hoosier Healthwise. Those individuals on HIP 2.0 that are pregnant at their redetermination period, they would automatically need to switch over to the Hoosier Healthwise program. They couldn't remain in HIP. We also are required to give pregnant mothers a choice to transfer to the Hoosier Healthwise program if they're on HIP when their pregnancy is, when they give the state a notification of pregnancy. And the pregnant mothers between 139% of poverty and 208% of poverty, so those who make more than the eligibility for the Health Indiana plan expansion would remain eligible for the Hoosier Healthwise program. There is no cost sharing during pregnancy. However, after the delivery of the baby, the coverage terminates 60 days postpartum. So it's really this termination of coverage in Hoosier Healthwise after the 60 days after delivery that discourages continuity of coverage. And so that's really why we are seeking, and we sought in our waiver, to maintain continuity of coverage in the HIP program to allow pregnant mothers to stay on HIP during pregnancy. There really is no difference in their cost sharing, whether they're on HIP or Hoosier Healthwise. The only difference in their coverage would be having a health spending account, the health savings account component of their coverage during their pregnancy, and having that ability to use dollars out of that account to fund their services. The Hoosier Healthwise program also has incentives for healthy behaviors and receipt of preventive care, and again, also in the Hoosier Healthwise program, newborns remain in coverage for up to a year if their mothers were already on our program. All right. Wanted to talk about the importance of health plan selection for our pregnant mothers. So prior to 2015, we had a 14-day choice period where we put women who did not make a plan selection on the application who were pregnant into a waiting period to make a plan selection. And that waiting period was 14 days before we auto-assign them to a plan. We think that 14-day waiting period really delayed getting them into the prenatal care that they need. We would like to think that the fee-for-service program provides the supports necessary to get women into prenatal care earlier, but really it's not set up to do that, and we don't do a great job at getting women into prenatal care, but the health plans do, and they have financial incentives to get women into prenatal care sooner, and they also perform risk assessments on pregnant mothers to determine whether their pregnancy is high risk, and then they're able to get them into high-risk pregnancy case management programs. They're able to assign them social workers to be a health advocate on their behalf. They are able to enroll them into tobacco cessation programs and really assure accesses to services that the baby may need after birth. Fee-for-service program is ill-equipped to link women to those supports, but our managed care partners are. In Indiana, we have 3 health plans that the state contracts with for 80% of our Medicaid population, and those are Anthem, MedWise, and Managed Health Services, a subsidiary of the Centene Corporation. This year, we eliminated that 14-day waiting period, And now for women that don't pick a health plan on the application, we automatically assign them to a health plan at the point of application and transfer their file to the health plan so they can get them into prenatal care sooner. We heard from the health plans that the fee-for-service period was really inhibiting their efforts to improve quality scores and HEDIS measures related to pregnancy, because in actuality it was more than even 14 days. It sometimes could be 30 days before their file was being transferred to the health plan, and really the health plan was able to manage their health care and get them into the prenatal care they needed. The recently published managed care proposed regulations would require states to have a 14-day waiting period for all populations if the member does not pick a plan on the application. And we think that really would inhibit the efforts that we've made to get women into prenatal care sooner. And we've made our comments back to the department that it would really delay that much-needed prenatal care. We also have created a non-payment policy for early elective deliveries. So unfortunately, we identified that there were mothers in the Medicaid population who chose to deliver their babies early, and sometimes for different reasons. And those reasons could be, they were feeling discomfort, or the mother's discomfort during pregnancy, or she felt it was more convenient to deliver earlier than 39 weeks. Sometimes physician office schedules, if their doctor was going on vacation, the doctor might encourage them to deliver early. And preterm birth, as we all know, have substantial lasting effects on the infant's health. It can affect lung and brain development, and leads to higher stays in the NICU, which leads to higher NICU costs. In Indiana, the average cost of a NICU stay per day is $3,757. So about 3% of our babies born in the state were earlier than 39 weeks electively, that being the mother chose to deliver early. And that in the Medicaid population equates to about 1,200 deliveries a year who were early and elective. So starting on July 1st, 2014, Indiana Medicaid adopted a policy of non-coverage for elective deliveries earlier than 39 weeks. We did make exceptions for birth when it was spontaneous or medically necessary as determined by a clinician, and we have a list of what those medically necessary reasons are. And we became the 4th state in the country to adopt a non-payment policy for early elective deliveries, with the other states being Texas, South Carolina, and New Mexico. We've already seen good results from our non-payment policy. We think it's driven the percentage of early elective deliveries from about 3% of all births in the state down to 1% in a little over a year. So it's already had an effect at discouraging early elective deliveries. And finally, I wanted to talk about long-acting removable contraceptives. So these are contraceptives that are implanted in the hospital setting after a birth. And so after delivery, a doctor can have a conversation with the mother about whether they want a permanent but removable device inserted that can prevent future unplanned pregnancies. And it really helps reduce unwanted pregnancy, particularly in teens. And we do have a very alarming rate of teen pregnancies that are repeat teen pregnancies. So we know once a teen has a pregnancy, perhaps most often unwanted, they're very much more likely to have another unwanted pregnancy soon after that. We identified that our payment policies around long-acting removable contraceptives were actually discouraging the use of them in the inpatient hospital setting. They were bundled into a set of services and a DRG provided in the hospital inpatient setting. And our hospitals around the state were stopping using the device because they felt they were no longer being reimbursed for it. The committee that I talked about earlier that's helping the state make recommendations around infant mortality encouraged Medicaid to adopt a policy to remove LARCs from the DRG and reimburse separately for those devices, which we have agreed to do. So starting on June 1st this year, we became the 13th state to unbundle LARC from the DRG reimbursement mechanism. And you see here the other states that have already adopted that policy. So we understand that that is already starting to have an effect on the likelihood that hospitals around the state will now use the LARC device and promote it amongst women during delivery. So Catherine, with that, that ends my part of the presentation.